Okay. All right. I want to welcome everyone back from the break. I'm sorry if I confused you with different times, but we're back. We are at the section of our program where we'll open things up for a roundtable conversation and a question and answer period. We'll conclude with some final words from our presidents at the end. Again, I want to thank all of our speakers for everything that you've shared with us so far today. We had a number of other comments come in from Felicia's talk in the chat, just acknowledging how great your talk was, as well as how important grassroots advocacy is. Let's open things up. Again, I invite folks to put your questions into the question and answer box. I can answer, or I can ask an initial question. We haven't talked about trauma, community violence, or just personal trauma, and how that impacts pain. And the overlap with the disparities that we've been talking about. What can you all say about that? What are your thoughts about how trauma, victimization, trauma exposure relates to pain, cancer-related pain, and some of the disparities and inequities that we've been seeing?
So Dwayne, I started my talk with those two narratives from the community. And I think that's what a little bit of what I was trying to get at was that the trauma that they were facing, the one woman was talking about trying to keep her kids safe. That was actually Felicia, that was in St. Louis. But she was talking about how she wanted to keep her kids safe from everything that was the community violence that was going on. If she felt like she was in too much pain or too sick to care for her children, then no one else would. And so she was afraid to actually go and get medicated because she was afraid she wouldn't be able to properly be there and be present for her children. And I think in the second situation, it was just the overburden of so much happening and so much going on around the person that that kind of exasperated the trauma and delayed the connection with care. And so I do think that there is some, at least on the community, speaking from the community perspective, I think that there is definitely a intersectionality between the social unrest and the social determinants of health and the trauma that is experienced within the body and mentally and socially for our cancer patients.
Terry, can you, there you go.
Yeah, I did. Nothing's getting past me at the last 10 minutes of this gig. What was I going to say? We were working on the second edition of the Oxford text, and I was reviewing a chapter and wanted to integrate information about trauma or suggestion of trauma into a narrative of an African-American patient and family. And it was suggested to me that we have to be really careful about pathologizing people's lives. And I hear lately so many people talking about their post-traumatic stress disorder. And I'm like, really? First of all, it doesn't even meet the criteria in terms of a time and so on and so forth. So I think there is certainly a relationship. I actually think that some of our systems cause that trauma. I think cancer treatment causes trauma. And certain pains relate to the treatment that have been designed to save people's lives, but they end up with pain, right? Neuropathic pain for the rest of their lives. So I think it's related, but I was also very cautioned by the idea and by the thought that we need to be really careful when we talk about trauma and not pathologizing or not adding pathology to people's lives when some of those lives have yes, they've had very, very difficult experiences and ended up being quite resilient and so on and so forth. So I think it requires assessment. That's what I think. And it requires what Keith Walu talks about, the situatedness of our patients and our families. Where are they situated in terms of race, environment, economics, all those things that we put together, which reminds me, and I forgot to say this during my talk, so I could say it now. When I look at the list of people who are undertreated for pain, and we think about intersectionality, and we think about the vulnerability of women as it relates to pain, people of color as it relates to pain. For example, if you don't speak English as a primary language, and you put those factors together in one human being, it's interesting to think about how that increases the vulnerability, how the intersection of those identities increases vulnerability. And I think maybe, that didn't hit me until I put this talk together. I think maybe also that's an important observation for us clinicians who are observing a situation in terms of understanding what person may be more vulnerable to our delegitimizing their experience and so on and so forth, and what person may be less vulnerable. And when those certain factors come together, that we have to be really paying very good attention to the vulnerability of folks who have those intersecting identities. So I worry about trauma because I keep hearing people talk about they're traumatized, they have post-traumatic stress disorder. Since COVID-19 and since COVID, it has become used very easily, and that just worries me. It worries me that we're separating, we're sort of diminishing in some ways the true experience of folks who are traumatized by whatever the experiences have been in their lives and their current living, and what we also do to people in terms of creating trauma, which is why predictable pain needs to be well managed, because we don't want to create experiences that leave folks traumatized by us because we don't know how to do that well enough.
Mm. Terry, you've talked a lot about delegitimization. Right. Such an important point. You know, it makes me think about just invalidation, the invalidating experiences that can occur within our healthcare system, within our communities and families, and the disregard and the pain and suffering, the emotional pain and suffering that comes from that. And Felicia, when you talked about your father's story, where he said that nothing frustrated him more than not being understood by his providers, made me think about what Terry was referring to. Okay. Is there anything else you can add to this idea of invalidation within healthcare and in the disparities or inequities that we've been observing? And that's that question is for the whole people.
Mm-hmm.
Well, I can just speak from that perspective of my father, and I also enjoyed Dr. Smith talking about while she works in the profession and was trying to help her father along when he was managing his cancer, trying to make sure that you're working with them, answering the call, talking to the providers, getting an understanding if they're really taking your family member seriously, even though you work in a setting where you understand these issues to a T. And even in some ways for me, being in the DC area, my father being in Memphis, I always feel at a disadvantage because I'm not going with him to his doctor's visits. I'm not going with him to make him feel comfortable to ask those specific questions. So every time he comes home and says, well, I asked the question, but he dismissed it, I'm like, again, that's a way of him not being heard his pain not being legitimized. And but I'm also feeling powerless too, even though as a professional, how could I be helping? So it's just it's one of those things that is unfortunate that continues despite all of people's good efforts. But I think what needs to start is having providers start legitimizing it, educating them. The cultural competence piece is very vital, and meeting patients where they are. Otherwise, you won't. This systemic issue will continue, and it's an unfortunate issue that is prevalent amongst communities of color.
You know, I who am technologically challenged, as I was listening to you, I was thinking that the next time Dad goes, you should FaceTime yourself into the meeting. You know, what COVID has done for us, we would never be doing this if it weren't for COVID. I mean, if you think about it, what COVID has done for us really is to open up a whole different way of teaching each other and learning and participating, no matter how many hundreds of miles you are away. And I think that's really, that's really a benefit. And it's an interesting option. Now, whether your dad would want that or not is a whole other conversation, because, you know, whatever, you're the kid, however you would see that. But it is something that, and I can imagine the clinician would be slightly anxious, but we don't really worry about that. We can help clinicians with their anxiety. So I think that this kind of modality and this ability is going to, has the potential to change things in a way that we never had before, because it wasn't really upfront in our minds that we could zoom into an appointment with our mother or our father, you know, halfway across the country, and listen. And maybe that is all that we would do, would be listen. But we also have an opportunity to contribute in different kinds of ways, So it's not so isolating sometimes, and for everybody, for the person in the room and for the family trying to understand how they can be helpful.
My mother just went through her second round diagnosis of breast cancer, and the oncologist, all of the oncologists, the surgeon, the oncologist, and the radiation oncologist all let me Zoom, FaceTime in for every one of her appointments with them. And they stopped and asked me if I had any questions or if I understood. And so that after the meeting, I could then, because my mom's in Michigan, so afterwards we could talk about it. So it definitely was something new, but I felt included, and they made sure I felt included, and they, you know, in those meetings, in those sessions. It was really great, actually, Terry.
Yeah. And then I think the other wonderful thing that can happen is you will hear things as daughter, and mom hears things as mother and patient. And you can have that kind of rich exchange about the different hearings, right? The different listening that we couldn't do in the past. We just couldn't do it. Yeah.
Julie has entered an observation in the question and answer, and I'd like to read it so that everybody can hear it and weigh in on her observation. Julie says, over the years of being a clinical social worker in palliative care and oncology, I've learned that our patients are more than just their cancer diagnosis. As many have mentioned, it is critical to understand the narrative and context of being aware of what matters to our patients versus assuming that the, quote, illness is the highest priority for a person. The reality is that many patients and families are trying to live with cancer and manage practical issues of life, such as relationships with family and changes in roles. That's a really important and apt observation, Julie. Thank you for sharing that. Panelists, do you have other thoughts about that? Understanding what's most important to patients within the context of cancer and cancer pain?
I just kind of feel like if the participants of this workshop walk away understanding that and reflecting on that and incorporating that into their practice, then this workshop was quite effective.
Yeah, and I think if it extends to those of us and those in our families who have substance use issues, who are called addicts and junkies and all those kinds of horrific words that we call people. It's the same concept, right? That addiction or substance use disorder is a part of a whole person, and how we engage the whole person is the therapeutic work. So it really it, I think, speaks also so beautifully to when we are weaving together issues related to substance use, as well as cancer or any kind of diagnosis that somebody has, that somebody carries.
Yeah, I agree. Julie hit the nail on the head. I think that's the point of all of our presentations, is making sure that you're acknowledging that people aren't their specific illness. They have led a life prior to diagnosis, and they still lead a life even with living with chronic illness or chronic disease. And so we have to be, as providers, as practitioners, even as policymakers, be knowledgeable that you're working with the whole person, not just their disease. They're not defined by that disease. And so one of the questions in the chat, Tricia mentioned about how do you motivate practitioners to be more culturally humble? Well, using the information that Julie just put out about the whole patient, I think that is how you can really engage. There's a way where we can really be thoughtful in engaging practitioners to get them to be more culturally humble, because you're looking at the person not just presenting as this patient is presenting with cancer, but no, this patient is presenting as a mom, as a caregiver, as a person who works 9 to 5 on different jobs, or is a career person. And you're looking at them from all aspects, and they also have cancer, and they also have this, not just looking at them as the disease. So I think for us, our mission, and everybody who's on this call, is to make sure that we are getting out there with the mantra that we're treating people. And I know if I was ever diagnosed with anything, I would want people to see me and not see my disease.
I think too, that relates to assumptions and to this whole idea of situatedness that I Keith Walu, I think, is fantastic, the way he understands larger issues, the whole issue of situatedness, and that we cannot make assumptions about people who are coming to see us, that it's a discovery process. It's a discovery process. And I think those who hang around this work for years and years, that's the joy of it. In many respects, is the discovery process of the richness of other human beings and how they've managed their lives, what they bring to it.
We haven't mentioned this phrase or this idea specifically, but I think we're talking about it, and that's the concept of total pain. How the physical aspects of pain plus the emotional, spiritual, psychological aspects of pain together add up to the total experience of pain. And again, I'm just wondering if you could speak to that a little bit more specifically. How can we think about total pain within this lens of minimizing disparities and achieving health equity? Can you say anything more about that?
So it takes me back to trauma, which is kind of interesting. What's floating through my mind now is trauma and how we discover, because total pain, for those who don't know about Cicely Saunders, was a concept created by Cicely Saunders, who was a physician, nurse, and social worker. She was trained in 3 disciplines. So she was like an interdisciplinary, she was the team in one body, and she founded the hospice movement in England. And it just strikes me that but it's not just, it's not really, so it's about trauma and what people bring socially, historically. But the other piece of it is about their values. And when we talk about cultural humility, part of what we're trying to understand is how people see pain, how people express pain. what it means to them. And that I was interesting as I was listening to you talk about rural communities, I was thinking many people in rural communities expect pain. They live with pain as a part of because they're physical laborers. And sometimes they miss a pain that's a harbinger of a terrible disease because they're so used to pain. But that's also happens in cities where people do hard work. So Dwayne, I think it's the same sort of bottom line aspect of discovery and what people bring together from their history, their values, that defines pain for one person, but doesn't necessarily make it pain for another, because of the way they see. I remember a patient who told me that when she felt pain, she knew she was alive. She didn't want that pain to go away because it meant she was alive. And so I think total pain is about discovery of a lot of the things that we've been talking about today, how those things come together when we get beyond assumptions of what we think we know up here. And because that's the other part of it, right? Different ways of knowing, and what people bring to their circumstance about how they know it in their heart and their soul rather than in their brain. And most of us are thinking with our brains.
Just to sort of continue the conversation that Terry's having, it makes me think, everything that Terry's saying is making me think of the concept that we always teach about meeting the client or patient where they're at. And I feel like it's like, precision. We talk about precision medicine, but we don't talk a lot about precision patient supportive services. And so it feels like it's like us sitting with them and actually taking a moment before we start all the diagnosing to listen and to meet them where they're at and to hear what they're saying and to incorporate body, mind, and soul into what they're trying to tell us is going on with them, and not separate that out from how we treat the total pain.
Thank you for that. A couple of other questions have come in the Q&A box. I'll read the first from Lana. Lana said, I appreciated the discussion focused on rural communities. Oftentimes, limited resources are of primary concern. I wonder if anyone has recommendations for how to support folks dealing with cancer-related pain and experience being, quote, bounced between PCP, medical oncologist, radiation oncologist, and pain management specialists for their pain medications.
The intervention practices that we're trying to do here involve community health workers trying to bridge those various or serve as a navigator, you might say, in the community. Obviously, this is a way of increasing the rural residents' social capital and sort of connecting them and with the information needed to decrease some of those barriers to connecting to those various multidisciplinary services. And so that's just one, I think, growing area where we're using many more, and the community health workers are from the community. So they're from the community, they're trained, they work in partnership with the interdisciplinary team. And they help to bridge, I think, some of those barriers.
So what am I thinking? I'm thinking that if there's a social worker in the oncology setting in this patient's life, then that social worker needs to get a call together with all the specialists. I mean, we do this for a living. It's like you get a call together with all the specialists and say, figure it out. One of you've got to be responsible. You don't say it that way, of course, because we know how to be professional. But think about the waste of money in terms of also time, transportation for people who are already sick and living in pain. It just seems that in this day and age of being able to connect folks, that we ought to be able to figure out a way to pull that together and help somebody say, I can be responsible for this. They hear each other and they decide who's going to be responsible for the pain for managing the pain of a person who needs coordination of care, because that's really what we're talking about. And not easy, but I think that that it is a care coordination role that social workers often take. They take responsibility for that. It's the same as post-hospital planning. If you're sending somebody home and you figure out that you think they can't get their medications, that's on us. That really is on us to make that better. We need to own that. We need to own it.
Well, as you said in the title of your talk, the time is up. We have to.
It's because I'm getting so old. It's like
no.
My level of frustration is higher.
Yeah. Well, what I mean by that is, I guess what we're getting at in this conference is that the time is up. It's time to act.
Yes.
These problems have gone on too long and have affected too many people, and that it is time to act.
Yeah, and I don't think I was so intrigued, Felicia, with your conversation, because when we were Pain and Society Fellows, Mayday Pain and Society Fellows, they took us down to Washington and they did all kinds of stuff about teaching us how Washington works. And now if you look at the news and see how Washington works, and it just makes you sort of hold your head and wonder, can anything ever happen down there? But then you think it could have been worse. So, but that said, I'm thinking that palliative care folks need not wait for Pachetta to get passed to do what they know they need to do in terms of teaching. I think that's also something that we as advocates, individual advocates, need to push our professions and need to push our organizations. That to wait on Washington, you might wait a while.
Well, Sarah has a very related question here. Sarah asks, thinking of what Felicia said about leaning into the personal stories for policymaking and advocacy, I find myself as a clinical social worker having access to many, many individual stories, but not knowing how to move those stories forward to the policymakers who need to hear them. Do any of the panelists have suggestions about that?
Well, I'll start. So just personally getting this presentation together, I was hesitant to even tell my father's story because it's so difficult for me, being his daughter, to even express what he's managing. But after watching him on a long drive from DC to Memphis, where he had to stop every 2 hours to manage to deal with his pain, I realized his story has to be told. And so when you think about that and how you package it to talk to policymakers, I would encourage you to first talk to the policymakers within your organization, or people that you're working with specifically that lead your organization. So CEOs or lead physicians or lead social workers, and take those stories first and elevate them to the people within your particular hospital setting or wherever you're working, and talk to those policymakers, because they do make policy. They create policies within the organizations that they function in. And then on a personal note, outside of your profession, if you're active in civic engagement, I would encourage you to be participatory in the local election process, because local is where the rubber meets the road and where a lot of ideas and decisions are made that really impact people on their everyday lives. And use those stories in going to town halls and talking before boards and systems to express what's going on and what you're seeing within your profession as it relates to communities of color or as it relates to your particular practice. And then on a federal level, utilizing organizations like the sponsoring organizations for here, whenever there's a call to action, you can always take the formal letter that they may send and say, oh, support this legislation, and craft your story of your personal stories of your patients that you've captured to amplify the mission and the goals of that grassroots advocacy. So it's levels to how you can do it, but that local piece and that that practitioner level, I think would be instrumental in moving the needle forward quicker. As Dwayne just and Terry just hinted, DC is clogged up with a lot of things, but it can be a bear sometimes. But local, as I've always said, rubber is where the rubber meets the road, and you can really move a lot of things initially there.
Those are great ideas. I really like the idea of, when we get those pre-crafted letters to forward to our legislators to add that personal story. That's a great suggestion. Amanda has a comment in the Q&A that is really very relevant. So far we've talked a lot about how we can be advocates. Amanda asks a question that relates more to self-advocacy. She says, I think teaching the patient to advocate for themselves as well, in the event their social worker or care manager changes, the patient is the continuum always. What are your thoughts about that? How does self-advocacy fit into this conversation?
As I was listening to that, I was thinking that we used to, when we took care of many chronic pain patients who lived with chronic pain, like your dad, and we would teach those patients that when they had a pain flare, they needed to come into the ED and tell the ED staff exactly what medicine worked for them and at what dose. We used to teach patients that because we said that's what it means to be a responsible person who lives in pain. You know your body, you know what works for you. The environment has changed such that we would never teach a patient that now, because if they went into an ED to ask for a specific medicine, they would be accused of drug seeking. So the environment has changed, and I worry that we put on patients what we as responsible practitioners need to fix. And that's not saying that we don't teach patients how to be informed. We teach them about pain. We do lots of psychoeducation. We even teach them language sometimes to use with their providers. And that's all very important work. What I worry about is that we put more responsibility on the victims of what we know is a system that is broken and that does not treat pain well. And so that's my only worry. It's about balance, it's about balance and achieving balance in that shared responsibility to create systems that treat patients in the way they ought to be treated.
Self-advocacy can be really hard when you've been feeling marginalized, delegitimized, or don't feel like your voice will be heard.
The John Oliver tape, which I mentioned before, is profound. It's the part that is most profound is an African-American husband whose wife dies in childbirth. And what does he say? He said, I was afraid I would be, if I advocated, or if what I'm left with is this feeling that I didn't do enough because I was afraid I'd be labeled an angry Black man. So yes, self-advocacy is very complicated. I remember the patients that got discharged from our oncology practice were both African-American families, because folks couldn't manage, when probably we created rage by the way we interacted. We ended up creating what would eventually get people kicked out of clinic. So it's really complicated. I think that's the message. It's really complicated, and we have to own that rather than putting it on the patients and the families to try to figure out how to negotiate a system that is filled with inequities and oftentimes a broken system.
Yeah. Okay. One other area that we've just touched on a little bit, and Terry, you talked about the pandemic in one of your comments, but I'm wondering if we can come back to that. This is unprecedented time in our history, right? We're living within this pandemic. We have varying rates of infections throughout our country, varying rates of vaccination throughout our country. What are your thoughts about the pandemic, how it's affected cancer care, some of the inequities that we're observing? How has the pandemic intersected or impacted some of these issues? And what are your thoughts moving forward? What are some of the lessons learned that we can pass forward as we continue to live in this pandemic?
Well, I'll start and just say that a lot of lessons have been learned as a result of the pandemic, but some of these lessons have been around for a long time. I really think that more attention has been brought to systemic issues that have received a Band-Aid just in some respects of support, but not really looking at root causes. And so the pandemic has really allowed us to know that anything symbolic or performative won't pass the test anymore. We have to be focused on actually coming up with solutions to do better in our healthcare system. And, you know, as when it comes to the federal level and what we're lobbying for at CSC is really keeping the patient first and making sure that cancer patients had access to vaccines almost immediately, making sure that the Affordable Care Act, that the special enrollment period was able to be prolonged because that was important. A lot of folks were losing their jobs while trying to still manage, get care. And so we had to figure out ways where we could expand access and affordability of care. But also some of the lessons learned is that we need a robust public health system in the United States. We can't do things compartmentalized. Mm-hmm. And the pandemic showed us that this piecemeal approach to providing care has really caused a lot of these inequities. So what are we doing at a federal level to make sure that if unfortunately another pandemic happens, that continuity of care continues for patients with chronic illnesses? And it starts with having access to a public health system. And then moving forward to having more education of our practitioners and access to community health practitioners too, and people in communities that are traditionally under-resourced. The one good thing about the pandemic that I have appreciated is the use of telehealth and telemental health services. But there's also a caveat there. If people don't have access to broadband, then what is the point of having access to telehealth services? We have to look at things in a more holistic way and treat and see people more than just disease and come together as advocates from all over to build a more robust public health system. So it's lessons, but it's also, these are teachable moments that we've known for a long time.
You know, what's interesting is that one of the things that I didn't know, maybe I knew it on an unconscious level, is the different ways that people look at autonomy and relational autonomy, what we owe each other, what we think is within the realm of our decision-making, whether it harms somebody else or not. I think that's been very instructive and on some level demoralizing. Because it's been such a global look at the different values people hold about what we owe each other and so on and so forth. And I think that's it's just been so visible to me, and it still is. It just blows my mind that that a person's autonomy is wrapped around whether or not they wear a mask, that their whole identity is threatened by whether they wear a mask or not. I think I know on some level that existed in our country and in our world, but to see it as graphic as it is now makes you think there's just an enormous amount of work to be done. And maybe we don't change those people's minds, Felicia. maybe what we do is we take the knowledge that we have about inequities, which are global and in our face day after day, and we build on that, and we see what happens with those folks, because that's what's been amazing to me, is the absence of coherence around how we help each other, and it just makes me think that, the task isn't to spend energy trying to convince the other. The task is to take energy and build what we know has to be built, because COVID has shown us, and so did the murder of George Floyd show us what has to be built. So that's preachy, but I'm old, you see. So I've been able to look back, and I was like, what fantasy world were you living in, kid? You were like in La La Land. If you thought that there was some kind of shared belief system across this country, guess what? There ain't. Anyway, yeah.
Those are powerful thoughts and words. There's one other comment that came in, and this might maybe our last comment for the day. And it brings us back to us as providers and as people in the field. Richard asks, what role, if any, does the pain and trauma of the clinician play in building relationships? For example, dealing with time-limited meetings, second-guessing one's own interventions, dealing with one's own race and cultural traumas, etc. What do you think about that?
I think it's important for us to not forget that piece of it, because I think there is an element to, when you are building trust or you are approaching communities with humility, to doing that internal assessment of your own biases and what you're bringing to those tables as well, so you're aware of that. And I think that having your own humility allows you to connect and be vulnerable and transparent with others, to allow that dialogue to take place. So I think it's a two-way street. I think, and that's just me. I mean, I think my colleagues might have other varying opinions, but I just feel like it takes both that internal assessment as well as being able to listen and include others.
Mm.
We're all a part of the community, even the provider.
Mm. I'm not sure it's any different than the countertransference we talk about in the work that we do on a day-to-day basis. That kind of consciousness and ability to, when you have really, I think, and I've sort of made this up, I think that working in a team is an antidote to some of that countertransference, that when you have to be accountable to other people, that helps. And I don't mean accountable in a hierarchical way. I mean accountable because you're a team and you work in an environment of psychological safety, and you can take risks and be vulnerable. I think that teamwork actually helps with those kinds of worries, that somehow your own trauma is going to get, out of control and take over the whole course of what you're doing as a clinician. And I'm not sure that it is different, although perhaps it is, because we haven't had open discussions about race in the way that we seem to be having them now. And so perhaps it is more, people are more sensitized to it and don't want to do hurtful things, I think, though, that must be part of the process, that shared vulnerability, which means that you might make a mistake. You might say something that's insensitive, and then what is the response? How do you get a response to that? It's the risk for very, very important outcome. Because if we don't take those risks, forget it. We're going to be exactly where we are now, right? Or worse, because we will have missed an opportunity. We will have missed the opportunity. I don't know if that's helpful, but that's my wandering mind.
Yeah, examining our own selves is just as important as understanding the experience of others. and how our own experiences impacts our ability to do this kind of work. And just as many of you have, the points that you've made about the importance of personal stories and shared experience, our own experiences are powerful. We can learn a lot from them. And I think probably many of us have gotten into this field because of some personal experiences in our lives or families' lives that have motivated us and inspired us. And I just want to say that all the points that our panelists have made today are certainly very inspiring to me. And I've seen a lot of appreciative comments in the chat along the way about how important and helpful this discussion has been. So I want to thank all of you for participating. I think we can maybe move to our closing comments. We're a little ahead of schedule, but we've been ahead of schedule, so I think this is probably a good thing. I just want to open things up to our executive committee and presidents. See, Krista, you are on.
Yeah.
Yeah.
Thanks so much, everyone. I just wanted to share my gratitude really for this opportunity for our cancer community to connect around health equity and how we can even take small steps to come together to be part of the change. I felt really grateful that this information is recorded. I felt like there was a lot and I might want to go back to it. So I'm grateful for that. And I really just can't thank the panelists enough. You guys had given us a lot to think about. You gave us robust discussion, inspiration, and I think really have left us to consider as a community what our call to action is as a cancer community. One thing I want to put a plug in for ACCC, when you talked about how do you share your stories, we at ACCC have a lot of opportunities to connect with your local legislators, and that we have a virtual Hill Day or a real in-life Hill Day, so lots of opportunities through that. And just a huge, I can't say enough for the sponsors. Thank you so much, Eli Lilly, Takeda Oncology, and Janssen for your support. So I'll turn it over to you, Bill, if you're on.
Thank you, Krista. I first really just want to give a heartfelt thanks to all of the presenters today. You were all so thoughtful in your remarks, so informative, and really just so inspiring. And I am grateful that this session is recorded, and that I'll be able to come back and watch your talks again, because I know that I'll want to. I am also, what I kind of came away with too from this conference is how collaboration is crucial in so many ways. And I thought it was great that our three organizations were able to collaborate in putting this together. And I just think there will be so many more opportunities for us to do things like this, whether it's a conference or something else. And, it even gave me ideas on just even collaborating with others at my institution, even though I'm only working there 1 day a week now, but hey. And again, a huge thanks to the sponsors for helping to make this possible. And you really came through for us. So just ending with gratitude and handing it over to Joe.
Actually, I'll step in on behalf of Joe.
Okay.
I think he had to step out, but on behalf of Joe and the rest of the APOS leadership, I also want to echo these sentiments. It's been a great collaboration. It's wonderful to be able to do this. I really appreciate all that our speakers have provided us with today. I'm amazed at how many people attended. Thank you all for being here today. I hope this has been a helpful and informative experience that you can then bring back to your respective organizations and move this forward. Thank you.